The next talk will be given by Dr. Bhimaraj on devices and surgical therapy for advanced congestive heart failure. Dr. Bhimaraj runs our LVAD program and has special interest in cardiogenic shock. Dr. Bhimaraj.
How many of you here treat patients with heart failure? Raise your hands. Or are involved with patients with heart failure? Raise your hands. How many of you here treat, see, or are involved with care for advanced heart failure patients? More than you think you aren't. So hopefully I'll convince you by the end that advanced heart failure might be right under your nose because they're more challenging than what we think. So thanks for having me today. Thank you, Alpesh and Dr. Zoghbi, to talk about devices and surgical therapy for advanced heart failure. I'm not a surgeon, but I always probably think I can do a good job with my surgeons by next to me. I qualify as a surgeon because I put my hand into the chest when we retrieved hearts, but I'm a cardiologist. But even then, I'm talking about surgical options because we deal with mechanical support and advanced heart failure. Those are my disclosures. But before we talk about surgical options, we all need to identify what advanced heart failure means and then figure out that we're picking them up and then talk about options that are available for these individuals today. So one thing the future is going to get to us is no matter what specialty you are in, no matter where you are in the healthcare industry, you will end up crossing your path at some point with patients with mechanical assist devices. They're getting appendectomies, they're getting ophthalmological procedures, they're going to the ER. There are stories where people are in the ambulance where you have to care for them. So it's good to know enough that you know that this is what it is. Now, Dr. Park pointed out the stages, and this is the area that we're talking about, but my editorial always is this is the tip of the iceberg. Everybody who cares for the heart failure patient should remember that keep them here, don't send them to us, as long as you're able to do things that you can to keep them here. So medications, making sure they're on the right thing so that they don't progress is very important. Advanced heart failure doesn't always look one form. They're not always in a dying state. They're in front of you looking normal, looking like a young person with no heart trouble, but can still have advanced heart failure. If you have advanced heart failure, this is a classic slide which tells us that end-stage heart failure is worse than many cancers and probably close to pancreatic cancer, which we all learn in the healthcare industry as a very bad prognosis. So knowing that this patient has advanced heart failure ending up in end-stage heart failure is very important because they don't look always as sick. Also, the transition of stages, stage C to stage D is end-stage heart failure. Stage C is where we see patients with symptoms. Before stage C, you probably don't see them because they have no symptoms. These slides actually show you it's from a large center in Atlanta, in Emory, where they looked at all their patients and found that patients over a period of 3 years progressed at a rate of about 4.7% per year to stage D. But what's also important is as they're progressing here, which is 12% at the end of 3 years, equal number of people died even before they made it to stage D, which means there are patients who got missed picking them up before they ended up being diagnosed as stage D. I would encourage all of you to this document, the 2017 Consensus Decision Pathway, for a lot of things other than what I'm going to show here. Actually, they have a very beautiful algorithm of how to start ARNIs, how to up-titrate medications for heart failure patients. So anyone with medical management for heart failure, that has a very nice algorithms in that. But criteria have been defined when you should think about sending patients to someone who's specialized in heart failure. A lot of them talk about diagnosis and exotic diseases, which you could suspect. But I want to point your attention to number 2 up here, which is chronic heart failure with a lot of symptoms mediated discussions. If you're on inotropes, your blood pressure is low, your creatinine is high, 2 or more emergency visits to the hospital. These are things that you can pick, saying that these patients are probably at bad prognosis. Predictors of mortality, there are gazillion. If you do the studies, age, socioeconomic status, but you can't sit there and send everybody who's older saying you're end-stage heart failure because age pans out. What has led to that is because there are so many predictors, there are easy tools that are available in outpatient practice. So if you're internal medicine and you're seeing patients with heart failure, on a yearly basis, you can easily calculate this as a mortality of individuals for 3 to 5 years. And it's an online calculator, and this is recommended by that guidelines. You just punch in all this information, and it'll tell you at the end of 1 year what is your expected mortality. And then if you know the expected survival of someone who's end stage, who needs an LVAD or a transplant, you have a competing survival for you to talk about these options. There's another scoring system which is called as heart failure. The one that I showed is heart failure survival. There's another scoring system which is heart failure survival score. I'm sorry, the one I showed you is the Seattle heart failure score. But if you combine both of them, you actually get a very good area under the curve of 0.76. What that means is that it's a good predictor of future events for these individuals and quite well validated. Now, these are practical guides when you see the individuals. Few of these are incorporated into the table that I showed you. But if you have seen the patient twice in the ED, it's not, some of the patients actually say, it's Christmas time, I eat and come in and get my annual shot of Lasix. They're used to it. But getting hospitalized is not as benign biologically. Forget about the economics, the readmission rate, and all the discussion we're having in the country. But biology of heart failure, 2 admissions, you do bad. Progressive renal function worsening, weight loss, intolerance of medications. If you're backing off on the medicines because they're not feeling well, that's not a good sign. That means your neurohormonal cardiostatus is not working well, and it's a sign of failure. Low blood pressure, inability to walk a block. And that's a tricky statement because people get used to it. They don't tell you how bad they are because they've changed their lifestyle. So it needs a little bit of a history and probing them to know exactly how bad they're feeling. And then industrial doses of Lasix, bunch of metolazone, torsemide. If you're trying all those things, that's also a bad sign. And sodium is another good marker, and then frequent ICD shocks. If you have any of these profiles, these individuals are advanced heart failure. Hospital admission, and I threw this slide up there because it's a very clear reflection. If you have, the yellow is 4th admission. If you had 4th admission in your lifetime, you look at your 1-year mortality is up to almost 50%. The first hospitalization, 1-year mortality is 34%. So that's a very staggering statistic that individuals need to know when you're caring for patients with heart failure, and also patients with heart failure need to know that you can't just drink a bunch of water, eat some salt, and then just get your Lasix and you'll feel okay. Now, what is the solution when you reach end-stage heart failure? Transplant has been a historical solution, but it's been called as epidemiologically trivial because we have not been able to increase the number of transplants. This graph shows you how flat the number of transplants in the world and in North America and Europe have been because of donor availability, because of lack of advancements in donor optimization. But this is what has led to advancement in mechanical circulatory support. In 2015, 50% of the patients who got a transplant had a mechanical support, which is a durable left ventricular assist device with which they went home and got a transplant. So it's become a very viable technology as a surgical option for advanced heart failure patients. And this graph shows you it's just skyrocketing. About 22,000 implants have been done in durable left ventricular assist devices and mechanical support devices. In today's in today's terms, each year there are about 4,000 VADs that are done in the country, while about 2,000 transplants, so it's almost double the number of transplants. And they're working well for the purposes that they were designed. They've become smaller and smaller. This is an old pump which was the first that was validated, and you see the sizes that are becoming smaller and smaller with an evolution of technology to pulse modulation, which we'll talk about in a little bit. So the kinds of left ventricle assist devices that we have available these are old. They're in the museum. No pulsatile flow pumps are implanted in today's world that are durable and you can go home. There are some temporary pulsatile pumps we use that stay out of the body called as extracorporeal. But everything which is intracorporeal, they're non-pulsatile. And think about that statement for a second. You have no pulse, which in one aspect is actually a new species of mankind. And we've taken it for granted today. But if you look into the history and talk to some of the pioneers, and we have the honor of being in an institution where a lot of this was developed with DeBakey and Dr. Noon. When I talked to Dr. Noon, this was not taken for granted many years ago. But there are so many patients today walking around without a pulse. So the most important thing to notice here is continuous flow means that the flow is continuous. It's taken over from the heart, and there is no pulsations. And that's how this rotor pump here, the differences between these two continuous flows, the second and third generation, is that the one in between here is continuous axial flow, which means the blood's being churned with an axial flow pump in this direction. While centrifugal flow, the next one, is where the pump is generating flow with a pump in this direction in a centrifugal manner. No matter how it's generated, it's continuous flow because blood's just being pushed in a continuous manner. Now, the fourth generation I put up here is a continuous flow with some flow modulation. So now people are beginning to experiment because of some of the complications we run into. Maybe there's a need for a pulse. So the fourth generation is where the pump modulates with its flow to an extent that you have a little bit of artificial pulsatility, and that's been the latest advancement we have here. The fifth generation is being made in Hollywood, but probably not yet available. Tony Stark is working on it. So that's the anatomy. I think I explained to it. Blood is sucked from the left ventricle. The pump generates the flow. I don't think this is working here, bro. And then you notice that the outflow strainer pumps blood into the ascending aorta. And that's how essentially you're taking over the left ventricle. A centrifugal flow pump is very similar, except that over here, this is put in a pocket in the belly, pre-peritoneal, while the centrifugal pump is in the pericardium, sucking blood out of the LV and into the aorta. On an X-ray, this is how it looks. And a total artificial heart, I put it up here, is not done as common, but in indications where you have to supplement the right side, you do a total cardiectomy. The entire heart comes out, and the total artificial heart essentially gets sewn onto the atria. The heart is thrown out, so it's a total cardiectomy that people can get it viable, available, not as many. And if you look at the survival, at 1 year, you have close to 86% survival if you get an LVAD. This is all comers, sickest of the sick patients to some who are not as sick. That is much better than if someone's end-stage heart failure, their survival is 20% at the end of the year. And that comes from data that we've seen through previous VAD studies. So this is quite viable. Now, of course, there are a lot of problems that we still have to figure out. People are staying alive, but there's some amount of morbidity with strokes and GI bleeds and issues which we're learning. If you think about it, these have been approved only since 2008. It's relatively new. And the most latest advancement was the Momentum 3 trial, where that pulse simulation pump that I talked to you about, HeartMate 3, actually showed a major improvement to the older HeartMate 2 pump with a significant difference and improvement in stroke and pump clots and pump thrombosis. So the field is advancing more and more to a point where these are some pictures of our patients who go back to normal life. The youngest patients we have are brothers who are about 18 years old with myotonic dystrophy, and the oldest is about 82 years old. And everybody goes back to a good quality of life as long as they go through the initial phase of the risk of the surgery. In fact, a bunch of them have a hunters club, so they were featured in their newspaper, bad for the deers, but good for them. They've been able to get back to a good quality life. They're called as heart hunters. And we've had a long history with Dr. DeBakey, and actually the continuous flow pump was born out of one of Dr. DeBakey's patients when he was working on total artificial heart and the concepts of artificial heart, was a NASA engineer. And he was waiting for a heart and got a heart transplant, after which their collaboration is what led to the NASA scientists getting involved in the development of continuous flow technology. It took a while, and Dr. Noon jokingly says he asked the engineers one day saying, "You guys put a man on the moon, you can't figure out a simple pump to put in the human body." And reportedly they said, "We got paid a lot more to put a man on the moon, so it's going to take its time." Thank you very much. Appreciate it.